States of America, and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
That is the best vision statement ever.
Mrs. Edwards.
Here.
Mr. Ruiz.
Here.
Mrs. Labuda. Mr. Sorensen. Mrs. Geiger.
Here. All righty, we're ready?
It's up to you. You're the chair.
I'm asking Anne Marie, she's the
Yes.
clerk.
Oh, yeah.
Thank you.
Ready.
So, Dr. Carlos Holden, thank you so much for coming at such a bright and early hour on such a nice, warm, tropical, balmy day. The reason that we asked you to come was that District Attorney Jim Farrell had spoken about a district attorney's conference that he went to. And the subject that you're going to be speaking about came up within the context of the DA. So this is public safety and law enforcement. And there's an intersection between law enforcement and health and family services. It's like two, hi Hal, come on in.
I'm here.
Oh, you're holding up the door, thank you so much. In that context, where law enforcement and health and family services intersect, is where you are, where this takes place. So we have some people from the Rural Health Network here, and hopefully what will happen today is that there will be an opportunity to raise awareness of what you're going to be talking about within the county, and it will be videotaped and YouTubed. So I didn't know that was a verb, but it probably is. So people will be able to access it if they weren't able to attend the meeting. So your presentation is 20 minutes, and I'll ask people to hold their questions and comments if they want to make notes and write something down. And then we can have the questions at the end.
All right.
All right?
Very good. Well, thank you very much, everybody, for inviting me here to talk about this. This is, an important topic and one that has been bedeviling us a little bit in the emergency department. We noticed a significant uptick in the number of folks coming in with prescription drug abuses. So, we did a little research and found this is actually an increasing problem, not just here, but also nationwide. So, without further ado, I'm going to focus specifically on teen substance abuse today, but this is also a problem among our young adults and even among some older folks as well. My name is Carlos Holden. I'm the medical director of the emergency department at Catskill Regional. So, quick show of hands here. Up here we have three things that are commonly found in contemporary society. We have a gun, a car, and a prescription pad. And let's just get a quick show of hands here. One of these three things is the most dangerous, and the other two are less dangerous in terms of the number of lives they take. How many people think it's the gun? Is the gun the most dangerous? Anybody want to vote for gun? No? Okay, how about car? Lots of people, get in car accidents.
Trick question.
All right, smart people. You know, it's a talk about prescription drugs, so it's going to be the prescription pad, but it is actually the prescription pad. This is a chart that takes a look since 1980 at the number of, at the death rate. It's deaths per 100,000 people from motor vehicle accidents, from all poisonings, and then specifically from prescription drug poisonings. As you see, we've made very good progress in, in auto safety, in, traffic laws, in just overall awareness, and then in how we do in terms of trauma care if somebody is unlucky enough to suffer a motor vehicle accident. So our death rate from motor vehicle accidents has come down significantly since 1980. Unfortunately, our death rate from prescription drug abuse has been on the rise, starting in the say mid-90s, and really more than doubling since then. If you look specifically at the teenage age group, I broke them down into 10 to 14, the sort of tweens and young teens, and then 15 to 19. The three leading causes of death in the tweens and young teens are number one is accident or unintentional injury. That's 30%. Next is malignant neoplasms. That's a fancy way of saying cancer. And number three is suicide. If you look at the older teens, 15 to 19, again, accident or unintentional injury is the leading cause of death at 41.7%, followed by homicide and then suicide. So in both teenage age groups, accident and unintentional injury is the leading cause of death. And okay, so all right, we know that you can, for accidental death, you can fall, you can get into a car accident, you know, and as it happens, those kinds of accidental trauma are much less common than drug-induced. If you take you know, prescription drugs, you're looking at a death rate of 13.1 per 100,000. This is 2010 data from the CDC. It's federal data, so this is nationwide. If you add in alcohol, that's another 8.3 per 100,000. So our total substance abuse death rate for 2010 was 21.4 per 100,000. By comparison, motor vehicles killed half that, 10.9, excuse me, per 100,000. And firearms a little less, 10.3 per 100,000. That includes the homicides and the suicides. So that's all firearm deaths in the country in 2010. So if you, you know, just do some quick math, you'll see that substance abuse, alcohol and drugs kills more people than drugs and cars. I mean, sorry, than guns and cars put together. So it's, you know, pretty astounding how big a problem this has become. Just to drive the point home, I put it in real big letters. The most common cause of death from kids 10 to 19 is substance abuse, alcohol and drugs. And a lot of those are prescription drugs, as we're going to see. So this is like a snapshot on any given day. It's from a SAMHSA national study on drug use. And they looked at an average day in 2010 and 2011. These are the number of adolescents from 12 to 17 who use cigarettes, alcohol, or drugs for the first time on any average day. And you see the numbers are in the thousands. Alcohol is still the most commonly abused substance in this population. But if you look at prescription pain relievers over there towards the middle, you know, stimulants, that's you know, those are commonly also prescriptions. That would be the Ritalin, the Adderall, stuff like that. These are you know, significant. The only illegal substance that you know, tops the prescription substances is marijuana, and of course marijuana is not responsible for nearly the number of deaths that you know, prescription opiates or prescription stimulants are. So this is concerning because you know how the song goes, the children are our future, right? So if this is the future, we need to get a handle on this, or we're going to have a lot more people dying from substance abuse. This is an interesting map. This is obviously the United States, and although it's you know, very tiny, you can see that they have it sort of sorted out by county. If you squint, you can sort of see Sullivan County over there in New York. And this is 1999 and 2000. This is the death rate per 100,000 from substance abuse. You see, if you look at the whole country, there are a couple of red spots, Northwest California, northern New Mexico, sort of Appalachia. But you know, most of the country, you know, the vast majority of the country is in the sort of 0 to 6 deaths per 100,000 for prescription drug abuse. This is 1999 and 2000. Fast forward a few years. Now, 5 years later, this is 04 and 05. Much more red on the map here. Instead of 1 or 2 hotspots, we're now expanding to cover, you know, significant areas of the country. Most of New Mexico, Arizona, Nevada, even Utah, California. That little blip in the Appalachians is sort of gradually expanding outward, and now we've got hotspots down in Florida as well. Fast forward another couple of years, and there's a lot of red there. So this is not just a Sullivan County problem. This is a nationwide issue that we're having, and it's sad because these are you know, these are people who are dying not from a medical cause like, you know, sepsis or a heart attack or stroke or something like that, but from drug abuse, and specifically prescription drug abuse. You know, stuff that's supposed to help you and be good is being misused, and unfortunately, tragically, is resulting in deaths. It's most commonly prescription opiates. This is the opium poppy. We've known about this stuff since 3000 BCE. That stone tablet there is in cuneiform. It's Sumerian, and that's one of the world's first pharmacopoeias. It's a list of medicines, and the opium poppy is mentioned on that. So this is not a new substance, but you know, we've gotten even better at purifying it and synthesizing what are called opioids, which are chemicals that are related to the opium poppy, but are synthetic. In fact, we all think of heroin as being a drug of abuse, but it was synthesized by Bayer to combat the problem of opium addiction. That's why it's called heroin. We thought, okay, we got this substance that is going to be, it's synthetic, it's man-made, it's not going to be like polluted, and it's going to be less addictive. So hence the name heroin, the hero drug. Unfortunately, it didn't turn out that way, as we all know. But there's a long history. You see the article there. This is from the American Journal of Pharmacology, and it goes all the way back to 1901 that folks have been trying to synthesize this stuff.
Who made it? IG Farben. Same people who
Yep.
use Zyklon B.
Yeah, this is in Spanish, but the translation is Bayer heroin syrup, and the slide on the ad on the left says for strong cough. And then on the right, the cough disappears, right? So we used to have heroin cough medicine way back in the day. Again, although we've been doing this for a long time, we have some, much more recent examples. OxyContin's on the right there, so-called hillbilly heroin because people can crush that stuff and snort it. Zohydro on the left was recently approved. It's Zohydro is sort of Vicodin without the Tylenol. There were some significant concerns that this might be something that people would abuse because since there's no Tylenol in there, you can take a whole bunch without having to worry that it's going to affect your liver. So this is the Vicodin equivalent of OxyContin or oxycodone. I'm amazed that the FDA approved it, but they did. So here we are. I'm sure we'll come up with some street slang for this, and people will start talking about doing Z or whatever. Okay, so here's another. This is another slide specific for kids. These are older high schoolers, 12th graders, and this is the. It's similar to what I just showed before in a different way. And you look at the substances that are highlighted in red. Those are all prescriptions or medicines. Like over-the-counter cough medicine, stuff like that. And if you take marijuana out and then you add up all these different prescriptions, you see they vastly outnumber all the other illegal substances like cocaine or heroin or ecstasy. This is 2011 data from the University of Michigan. So we have a big prescription drug abuse problem in the country. These pain medicines are a big industry. In 2001, we had almost $4 billion worth of prescription opioid sales. That number has risen in 2012 to $8.3 billion. So it's doubled in 11 years. They're out there. They're popular, and unfortunately, the side effect is that people misuse them. We have lots of data on this slide. It's a little busy, but basically we're in addition to spending more money for prescription opioids, we're also having to spend more money to get people off of them, right? The drug screening tests or the number of prescriptions written for opioid addiction has just skyrocketed. So it's a big problem and a costly one. People think that this is sometimes people say, well, this is just like a street people kind of issue. It's the it's the poor, it's the low class. Well, no, it's not. Right? That's Heath Ledger. He had oxycodone, hydrocodone, diazepam, timazepam, alprazolam, and doxylamine in his system when he died. That's from the medical examiner's office in New York. More recently, we lost Philip Seymour Hoffman to heroin use. So this is it's a big problem affecting all segments of society, not just the street people, homeless people, crazy people. It's everywhere. You could be a successful actor making millions of dollars and still lose your life to this. So all right, so I think I got your attention. Hopefully that this is a significant problem. So how do we intervene? We know that this is out there and it's killing people. So how do we intervene? Well, first you got to become familiar with the signs of opiate use. Some of you in this room, I'm sure, are already familiar, but if not, the signs of acute use, meaning a recent use that's still in your system, would be pinpoint pupils, some shallow breathing, sleepy, sort of happy, dopey kind of feeling, track marks. I have a slide of what that looks like in a minute. And if you're not using, if you can't get your substance, then you're going to go into withdrawal. In terms of social issues, if you have a kid who, generally is a very good student and does well, does chores, all that, and all of a sudden, is not doing all those things that they normally do, that can be a red flag, particularly if it's combined with financial problems, requests for money, or legal trouble, right? And the legal trouble sometimes is not necessarily related to possession of the substance. It could be theft, right? Why are they stealing? Because they got to pay for their habit. This is from a blog by a recovered addict, and it's an example of pinpoint pupils. If you look at the pupils on the lower slide, those are normal. And if you look up top, you see that her pupils are very, very small. She took a picture of herself when she was intoxicated. And then the second one is after she's been in recovery for some time. So that's what pinpoint pupils look like. It's a little hard to see, but hopefully you can get an idea. And if you look in someone's eyes and they're dopey and sleepy and their pupils look like that, that's a possible opiate intoxication. This is track marks. It's injection sites, on the forearm most commonly because it's easy to get to. But if people are trying to hide their habit, they will sometimes use other sites. Feet, out of the way places, pretty much anywhere you can find a vein, an addict will use, especially if they've run out of sites in their forearm. So I mentioned withdrawal. If if people can't get their substance, what does that look like? Well, they tend to be in a very bad mood, sort of restless, agitated, running all over the place. So running nose, watery eyes. Instead of pinpoint pupils, their pupils will be big and dilated. Nausea, vomiting, diarrhea, achy all over, and goosebumps. So those are some signs of opiate withdrawal. So if you're faced with a situation where you see somebody who you think might be having an issue, you sort of sort it into, all right, do we need to intervene immediately, or is this something where we have time? If they're not breathing or not responding, then you got to call 911. Our EMTs have and paramedics have the antidote for opiate intoxication. It's called Narcan, and it can be life-saving. There are actually some pilot programs around the state to make that medication available to folks who are at high risk for opiate intoxication, so that if they're totally sedated on their opiate and not breathing, their buddy could actually give them Narcan. That's still in the early stages, but probably more to come about that. And of note, if you call 911, let's say you're using with your buddy and your buddy's not breathing, if you call 911, there's a law to protect you from prosecution if you get your buddy help. So just FYI. Let's say that it's not to the level of, okay, this person's totally unresponsive and barely breathing, but you've got school problems, you've got some social problems, and you see that maybe something's going on. Well, time to talk. If you're a parent, or if this is somebody that you're mentoring or whatever, talk with the teen first. Denial is going to be common. They're going to say no, oh no, not me. You may have to have a conversation multiple times before they're willing to talk about it. So don't be surprised if there's some initial denial there. You want to be compassionate. You want to focus this on getting help, not how dare you, you're a rotten kid, you're miserable. No, because that's not going to help them, and it's not really going to help you either, because they're not going to get help. You want to say, all right, you have a problem, we want to get you some help, and we have some folks who are experts in doing that. We have various local resources that I'm going to touch on in a minute. If, let's say, it's the kid doesn't really want to go and sit in somebody's office, maybe there's some embarrassment going on, there are various hotlines available that you can call. SAMHSA is a mental health and substance abuse organization nationwide. That's their number there. And then, all right, maybe this person's not ready to get help, but you need to, you as a family are going through issues related to this. There are some organizations specifically for family members of addicts, like Nar-Anon and stuff like that. So that's the website for the Rural Health Network. We have various inpatient treatment facilities here available to us. We also have outpatient treatment facilities for people who are, a little bit more stable. I'm happy to distribute copies of these slides so that you don't have to write down all these numbers in case you need to refer somebody. This is a drop box for prescription drugs that's in the Fallsburg Police Department. We're working on getting a few more of these around the county. The idea being that, let's say, grandma breaks her ankle and gets a prescription for some Percocet, and takes a couple, but it makes her feel sick, so she doesn't really like it. She decides she'd rather stick with Tylenol. Now you've got a bottle of 12, 20 Percocet sitting in grandma's medicine cabinet. Teenager comes over, oh look, Percocet, whoop, there it goes, and now it's out in the community and getting sold or abused. So to prevent that, when folks have medicines that they're not going to use, we have these drop boxes. You can come in. They don't take liquids and they don't take syringes, but if it's pills, you can you come in, no questions asked, drop the medicines off. You can even take the label off. Doesn't matter. Just come in and get rid of the medication so that they're off the street, out of the medicine cabinet, and not in the hands of somebody who would misuse them. Okay, so up until now I've been focused mostly on nationwide data. Let's narrow it down a little bit into our county. This is the drug-related hospitalization rate per 10,000 people. These bars are very difficult and impossible to read from on the slide, but you can see, right, this is the top quarter right here, the blue, and you can see that we're over in that blue part. If you could read this text, you would see that number one in terms of the drug-related hospitalization rate is the Bronx, number two is Richmond County, and number three is Sullivan. So we have, in addition to this being a nationwide problem, it's also a pretty significant problem for us here locally. Setting aside New York City, this is, we lead the state in drug-related hospitalizations. One other resource is the Poison Control Center. You can always call them if you have somebody who you think may be having issues. This is specifically the numbers that they have gotten. You see there's an upward trend there. We don't have data for all of 2013 yet because they haven't sort of closed their file, but you see it's trending upward. And we have a lot of specifically oxycodone use here. The State Department of Health has some resources that you can access. Those are right there. Various federal resources as well. So we have lots of stuff out there to help folks. We just got to sort of raise awareness and direct people who are having trouble to the appropriate resources. That quote is from SAMHSA, and I'm going to read it, although I don't usually like to read from slides because that's annoying. Behavioral health is essential to health. Prevention works, people recover, treatment is effective. Sometimes people feel like, this person has a problem, but they're never going to get better. They'll always be a junkie. They'll always be an addict. There's nothing I can do. Why even bother to intervene? But actually, sometimes treatment does work. Sometimes people do get better. We see that in the hospital. We see people that, we may see bouncing in and out of the ER for a little bit, and then they get help, and we don't see them for a while. And, and then you run into them in ShopRite or whatever, and you're like, oh, okay, that's great. That person's doing better. So it can work. So I'll end by going back to that slide with the big letters from before. Substance abuse, and specifically prescription substance abuse, is the most common cause of death for young people. Although we're talking specifically about 10 through 19 in this presentation, it also applies to young adults, 20s, early 30s. But these deaths are preventable, and together working, both from a healthcare standpoint, public safety, law enforcement, everybody working together, we can prevent some of these deaths and save some lives. So thank you very much. I appreciate the time, and if anybody has any questions, I'd be happy to answer them.
Thanks. Yes,
Okay.
Hal?
Just my personal opinion, but you didn't touch on what the medical profession is doing about changing what they do. It appears to me the medical profession is the folks that are creating most of these drug addicts. And just to give you a brief personal experience I had, last July I go to the ER because I'm in pain. The ER doctor comes in and he says to me, on a scale of 1 to 10, how bad is your pain? I said about a 2 when it's there, it's not always there. And he turns to me, without asking if I was ever a former addict or anything, he turns to me and said, okay, I'm gonna start you on a morphine drip for a 2. I mean, if I said 10, I guess I would have been put in a coma. And so the problem I have with it is, a lot of people, that's the doctor, he knows best. where I told him, you know, that this isn't happening.
Right.
And he never asked me if I was a recovering addict, if I ever had an addiction problem. That morphine could have put me back in, if I was a prior addict, that morphine could have put me back into a problem.
Right.
And I'm sure I could have left that ER with a script for oxycodone or whatever I wanted. So what is the healthcare industry doing to check themselves with this problem?
Right. We have something called the Prescription Monitoring Program, and that's been actually a really good resource. It's now actually state law that before prescribing an opiate, you know, Percocet or Vicodin or whatever, you have to consult this registry. And it's a statewide registry that is maintained by both prescribers, so that when you write a prescription and it gets filled, there's a record of it, and that's updated in real time. Like, I've had people fill prescription the day before, and I can already see it, in the registry. It's the law that if you're going to write a script for, a prescription pain reliever like that, you have to check and see, because sometimes people were in the past doctor shopping, right? You go to one doc, you say, I've got bad pain, and I really need something, and they get a prescription there. Then you go, a few miles away to another doc, same thing, right? So that's aimed at, number one, eliminating the doctor shopping, and number two, prompting the doc to say, hey, before you write this prescription, you need to know about this person's history. So we understand that there's an issue. It's funny that that you mentioned that, because about 10 to 15 years ago, docs were under a lot of pressure from the other side. We got told, you're not treating pain effectively, you need to be more aggressive at treating pain, and the Joint Commission, which is the sort of the regulatory body over hospitals, had this huge initiative. Pain is the fifth vital sign. That's why we all get asked. We're all asking, what's your pain on a 1 to 10 and all that. And unintended consequences. We now do a great job of treating pain, but unfortunately sometimes too good. So it's a pendulum. It swung very far one way, and now it's sort of swinging back the other way. And hopefully we can find a good happy medium where the people who are in pain get treated, and but we're not overprescribing.
Alan, and then Cindy.
Just an observation. I think another major contributing factor are all the big pharma advertisements on television. From the time our kids are 5 years old, they're seeing they're being bombarded with commercials that if you feel this symptom, that symptom, go see your doctor and get some medicine. And I really think we need to start a national campaign, just like they did with smoking, to make it illegal for the big pharmas to advertise their advertisements on television. They're pushing people to go seek these prescription. If you listen to the commercial long enough, you hear all the side effects, which include death. Calling your doctor after you've died doesn't really help. So, I think that's really what's needed. And it worked with smoking. By taking the advertisements out of the children's magazines and during their Saturday cartoon hours, and having effective anti-smoking campaigns, people were able to make a difference. And I think that is what needs to happen with these pharmaceutical advertisements.
I would love that. I remember when that got approved, and I thought, oh boy, that's a horrible idea, because people, instead of having a real conversation, people just come and say, I saw this on TV and I want it.
They go to their doctor and they cite the very symptoms that they heard on the advertisement.
Yeah.
And so that's what's happening.
Cindy had her hand raised, and then Nancy.
It was really good, by the way. Thank you for coming. It really, pinpoints that we do have a major problem here with it. And I understand, the drop boxes. Nancy from Public Health has worked on that education-wise, providing information to the public. I guess my question is, I know that a lot of it is, on the state level, like regulatory. There's, locally, I'm sure that if you touched base with the medical, community, pharmacists, because I have had some of those conversations, and they know where certain physicians are overprescribing. So is there anything locally that can be done? Are there pharmacy organizations or societies or something that get together to try to determine how they can, up the oversight of, some of the abuse? Such things like, limiting instead of 30-day supply of a narcotic, it'd be a 3 to 5 day supply for something that's not, major. So is there anything locally? Because I agree with Alan, there needs to be a campaign, but who does that? Is the state doing that? Should we be doing that locally? I mean, what locally to be done? Because we realize there's a problem. And I think if we talk to the medical community, they're gonna tell us where it's coming from.
Right.
So what's there?
Well, we've already started, some outreach locally working with the Prescription Drug Abuse Task Force. We had a presentation and we invited every physician practicing in Sullivan County to come to Bethel Woods. I gave a presentation that was similar to this one, but a little more focused for physicians with some journal articles and stuff like that. So we're working on it. In terms of what else we could do, I'd like to get more into the schools and have more outreach, to school kids, because I think that's an issue. In terms of what else we can do for physicians, it's tricky. Like if we all hear anecdotally, like, oh, physician X is overprescribing. It's hard to. Some physicians have a pain management practice, right? Meaning that's their focus. So they deal with people who are in chronic pain, and some people legitimately need these medicines. So we have to be careful before we go, on a witch hunt and say, oh, you're writing too many scripts for this, so you're out of business. Because there are people who, can be responsibly maintained on these medicines for a long time. So I think it's more just raising awareness. We have these, new initiatives like the prescription drug monitoring program, and some other stuff where, we got to just get the word out, basically. I don't know that the right response is to say, Dr. X is overprescribing, let's go get him.
Well, I guess I've gotten inquiries from pharmacists. Where do we go with it? What do we do with it? We know what's happening. Maybe they even have the scripts or the data, to show. But somebody had told me that there was a federal commission that investigates certain, complaints from a pharmacy. Or is that true?
Well, there's the DEA, right? If you're going to write prescriptions for controlled substances, you're required to register with the DEA, and that's to prevent people from running a pill mill, basically. So if a pharmacist had a specific concern that a physician or other provider was inappropriately prescribing, they could bring that to the DEA.
And they're aware of that. They probably know how to contact them.
The pharmacists, yeah.
Okay, Nancy, you're next.
Yes, I did want to say thank you, Dr. Holden, for coming and providing this presentation. This is, I think, maybe the third time you've presented in the community somewhere. Dr. Holden spoke about the presentation to the physicians at Bethel Woods. Also, we have met with the school superintendents as a group to reach out to them and to offer some in-services and some education to teachers, faculty, perhaps even students in the future. The Rural Health Network is a task force of not just public health, where it's the lead, but the task force involves representatives from most of the people that are in this room, in terms of law enforcement, EMS, the hospital, the recovery center, mental health. And when we did our community health assessment recently and the community health improvement plan, our top two priorities, the second top priority is to prevent substance abuse and improve mental health in this county because of our county health rankings. And so we're doing what we can. Prevention does work, but our community does really need more resources in terms of prevention and treatment as well. I did want to mention the drop boxes. We do have 2 now. There's also one located at the Liberty Police Department. It's accessible 24/7, as well as Fallsburg. And we're currently working on an agreement with the Monticello Police Department. And we have one other drop box that we're looking for a location. This helps the community have a safe location where they can come and dispose of their medications so that they don't fall into the wrong hands, and get them out of people's medicine cabinets. So that's another prevention effort that we're working on.
I think also because it's such a, I don't know if you have a few words you want to say, Jim, but, the fact that you are comprehensively working with all the different communities within this, as a larger.
Cindy mentioned pharmacists as well, pharmacists are part of that as well, part of our task force. Doctor, I want to thank you for coming. I think your presentation was outstanding. I think the presentation at Bethel Woods was outstanding as well. We obviously have a situation here. When you look at the oxycodone rate of prescriptions in this county, it's tops in the state. 399 per thousand. And that's 2010 data. It's tops in the state. So when you look at those maps and you see the blues, we're the darkest of the blue when it comes to oxycodone. So we have a very high rate of prescription of oxycodone in Sullivan County. And we have to get everyone engaged, including the physicians, and I think we're beginning that dialogue. We're beginning that because we need to change this dynamic. As the doctor said, this stuff's killing more people than car wrecks, and you'd think, no, car wrecks is what kills most people at that age group. You'd be wrong.
Have you seen anything on your end, Alex, coming through 911 with emergency calls, responses, or?
We certainly get our share of overdose calls. I don't know if it's on the rise, and we haven't run it statistically, but we certainly get our fair share, unfortunately.
Well, one of the things that I think is really important, and then I'll go on to you, is that, raising awareness, at least for us on the legislature, that's the first step. If you're able to present to us like an action plan, what steps you all are taking on the rural network, and then if you want to come back at a certain time and give us an update, what I'd really like to see at some point, Mike, is if the SROs can come in and give us their take on what they see in the schools, so that we really feel like we're a tight community. And I agree with Nancy that once we set a certain goal and we take steps to move toward that goal, that we won't see Sullivan County in that bar the next time that you come. It's just an indicator of a lot of other things going on, and those are the things that we have to do on a day-to-day basis, as well as if we need a resolution to send to Albany just to say that we've planted this flag. We did that with the local law that you put in place, Jim, you brought to us, and then a few months later I saw that the state was going to be doing that. That was on the bath salts. So we were ahead of the state in that respect. And we really want to let you know that this legislature is very supportive of your work. Oh, I'm sorry, Cindy and Joe. Thank you.
You want first?
Oh, go ahead.
Cindy had one turn, so you can go and then she'll wrap up.
One of the things that first I'd like to thank the doctor for the presentation. It was fantastic. I've seen the slides before too. But one of the things that we haven't talked about is that addiction is a disease. It's an absolute disease. It knows no boundary, knows no income differences, knows no racial differences. If you get hooked, you get hooked. But it is treatable. It is one of the most treatable diseases that we have, far more treatable than some of the physical diseases that we have. And we know it works. So I know sometimes we get stuck on somebody doing heroin or these other type of illicit substances being criminals. Well, some of their activity may be criminal, but their disease is a real disease, and it's a treatable disease. So one of the things that we talk about as part of our group in terms of the drug task force, as well as the community services drug and alcohol committee, we talk about what are some of the community-based efforts that we can put forward to try to reduce the availability of the drug, because the disease concept is that you have a willing host, a toxic substance, and the ability for those two to get together. And if we can intercept this getting together, whether it's through prevention efforts or whether it's through prescribing practices, which, by the way, we have provided through the task force to some of our doctors some other methods that they can look at first before prescribing an opiate. So we are doing some of that stuff too. But we can't lose fact of the fact that this is a disease, and it's a very treatable, successful disease. The issue with the opiate is that it changes the brain. You know, the pleasure center of your brain when you're on an opiate is the highest it's ever been.
Even
Which
more
makes
than
it the most,
skiing or
which makes it
something
the
like
most dangerous because, you know, after repeated use, it becomes, used to getting that like that. So you need a little bit more to try to get that high that you once had, you know, and that's what makes it so pernicious. But it can be treated, you know. So please don't lose that fact. You know, prevention works, but definitely recovery works too.
Thank you. You wanted to make another?
Yeah, no, I just
Because
wanted,
it's almost 9:25.
Okay, while I was thinking of it, going back to what the DA had mentioned, that we're highest in the state in oxycodone. And why is that? Is that because Sullivan County has more prescribing physicians or, you know, set up pain clinics? Is that a factor, or?
Well, I mean, if you look at the rates, I think the second highest is Richmond, which is Staten Island. They obviously have a problem with that as well. It's been reported in the press extensively. But if you look at the city of New York, where there's lots of physicians, lots of doctors, they don't have the rates that we have. We have less people.
What
This is
do
a
you
per
con-
capita rate.
What do you
This is a per capita rate, so this means per 1,000 people, 399 have a prescription for oxycodone in Sullivan County. It's got to disturb people. It's got to.
It's
Why?
incredibly disturbing.
Why? And then
They have it
add,
done for the
well, wait a
bottom
minute.
line.
Then add hydrocodone. Now, I don't know, Doc, can you prescribe oxycodone and hydrocodone, or are they contraindicated?
You could, it would be unusual. but
All right, well,
you
there's,
could.
that rate is in the 300s too. So add them together.
So you're
It's a
saying
lot
it's
of prescriptions.
39%,
It's a lot of prescriptions.
$3.99 and
Per
Are they
capita,
coming
yes.
from drug treatment centers that we have, or from physicians' offices? Do we know that?
It
Because-
wouldn't be a drug treatment center.
No.
Drug treatment center may prescribe an Intercept, Suboxone or things
So
like
it's
that.
coming from
But-
physicians that are situated throughout Sullivan, not outside of Sullivan. So it's a Sullivan problem, because we have
Nancy,
more
can you speak to
pain clinic doctors.
Well,
Actually, there are several
Not
Like
necessarily.
yeah,
They could be
several
getting it someplace
factors
else and
involved in
bringing it
that.
here.
It's not just physicians that are prescribing. I believe that the overdose and death rate also includes illegal drugs, not just prescription drugs. But people who are buying and getting those drugs illegally, or from family members who are sharing, or, you know, kids who are getting them from friends. The statistics are, when we drill down into the statistics, I believe it's not just physicians who are in this county who are prescribing those medications. It's wherever they're getting their medications. One of the things that I was very happy about was yesterday I walked into a pharmacy and I saw a sign that says we no longer accept cash for prescription drugs, for pain medications. So that's a start, because people will get cash and get somebody's prescription and, you know,
So things
get them
like that.
illegally. So it's
Yeah.
not just the
Yeah.
physicians that are prescribing.
The other thing that we have to be very careful about are the unintended consequences of some of our prevention efforts. What we're finding now nationally, as well as in New York State, is that as we begin to restrict the access to these prescription pain medications, people go to heroin. When you can get a deck of heroin for $5, it's cheaper than going and get a six-pack of beer. You know, so it makes our efforts that much more difficult, but it's something that, you know, that we have to pay attention to also. You know, and that's really where, you know, law enforcement and the rest of the task force really needs to kind of intercede, because, you know, we can kind of control the controlled medications. That's why they're called controlled. And we can talk to doctors about prescribing practices, and we can restrict the access to those pharmaceuticals, but there's little that we can do in terms of the heroin that's just coming aboard. It's the number one biggest drug issue in the nation at this point.
Having said that, though, sometimes we worry, like, if we really tighten down on the prescription meds, we'll drive people to heroin. I say let's drive them to heroin. You know, if these guys pull somebody over and they've got a bottle of prescription meds in their car with their name on it, you can't prosecute for that. That's my medicine. That's, I have a right to have this. On the other hand, if you get pulled over and you've got a bunch of heroin in your car, guess what? That heroin's going away.
I don't know if Blake likes that statement.
Well, the other part of that.
Maybe if the
though,
driver's
is-
drunk, they can up their arrest
Doctor,
records.
is there any difference? Really?
Medically, no.
I mean, if I take oxycodone, am I gonna get the same feeling I get when I take heroin?
Pretty similar.
Okay,
Pretty similar,
so,
yeah.
I mean, come on. A duck is a duck is a duck.
Yep.
If it quacks, it's a duck.
It's a disease, regardless of what that, toxic substance is. It's an addiction.
I understand, but we shouldn't be getting people hooked on these pills.
No,
and driving them to the pills or to the heroin, either.
It may not have been a disease.
And it's highly addictive, correct? These
Yes.
medicines, as you said, the brain wants more, the body wants more, craves more.
Yep.
I'm going to cut it at this point now. It's 9:30, and obviously this discussion can run and run and run. I'd like you all to come back in 6 months, sometime September. Do you think that's a good time to come back and reconvene and say,
Sure.
these are the things we've done? And Mike, that we have some school resource officers come back and tell us how they're doing with the schools. And I think this is an annual thing, right? 19th Annual Alcohol, Tobacco, Gambling, and Drug Abuse Poster Contest. So I'd like to offer you 2 signed posters from this is Olivia McCarthy, she won the contest, and Katrina Mendez. There must have been about 200 kids that came to the lobby, and the posters were all around the atrium, and it was, just seeing all that young energy to stay pure, and not fall into addiction was a beautiful thing. So I'd like to
Thank you.
offer you these posters as a thank you for coming.
I appreciate that. Thank you very much.
All righty. I'm gonna have to ask.
Sure.
Oh, was that a photo? Stand there.
Cora, I can't see it.
Yeah, that was the point. This is how the sausage is made. And your colleague, Laura, thanks so much for coming.
Thanks, everybody.
Thank you. So we're now going to continue with the rest of our public safety and law enforcement.
Just have to get my thumb drive there.
Oh, sure. Don't leave without it. And can we put this on the website?
Sure.
Okay.
Yeah, who
Josh,
should
is
I,
that- Josh,
should I email?
Josh Potosik, can you give Dr. Holden your card, and he can email you the... Oh, sorry, Annie will do it.
You're welcome.
We're going to go very quickly through the reports. I'm sorry that if there's a pressing issue, we'll go through Alex. Greg isn't here. The DA, Jeff Molinelli, and Mike Schiff from the Sheriff's Department. And then we have 3 resolutions from NISAC that we'll cover very quickly. So Alex, would you like to go first, please?
Sure. Everything's running smoothly at 911 over the past month. Like everybody else, we're looking forward to spring. We do have a construction kickoff meeting next week for the tower construction project with Midstate Communications. And they're going to start with building Tanana Lake and Thunder Hill, or rebuilding, I should say. So that's moving along. And we do have a grant application due at the end of April. Working with Art Hussey to get the resolution in to go ahead and apply for that. It's a PSAP grant, so I don't know that it's going to offset much of the construction or radio project. It's more for 911 center upgrades, computer upgrades, virtual
Right.
consolidation, stuff like that. Not so much infrastructure or radio, but we'll see what we can do to wiggle in something to help offset the 10 million project.
And the round 4 hasn't been announced yet.
Round 4, I anticipate probably around the state budget time, so maybe another month and a half, we'll see round 4. And those are typically the significant infrastructure, radio communication grants that, we've been successful with in the past, so we have our eye out for that.
Also, do you mind just running your stats on the topic that we had before? So the next meeting, you can just tell us what you found? Okay, I appreciate that. Jim's not in the room at the moment. Is Jeff with us?
Yeah.
Yes,
There he
thanks so
is.
much. How is everything?
Everything's going pretty good.
That's good to hear.
We were audited by the state, the Office of Victim Services for a crime victim program last month. And,
Okay.
The audit results were in last week. No major issues. We just received their annual probation and state aid plan this Tuesday, and I'll be working on that for the next month. We'll do on the 25th of April.
Can you give us an update on how the video conferencing thing is working? Because I don't know how many months it's been up and running now.
It's there's no issues with it right now, major issues. It's being used regularly both by the individuals that write pre-sentence reports and for the ATI program to have individuals released from the jail expeditiously. Every time I go there, it's always in use.
And how it's working okay from your end, the video
Yeah.
conferencing? So all the bugs have been worked out?
All the bugs.
Okay, that's
now.
wonderful.
Until
Let's-
tomorrow.
Yeah, it's technology, so something will come up.
No, we just want to hear it's all good. Mike, how's it going?
It's going. Blake, do you have anything?
How's our jail population? We exporting anybody?
No,
or?
that's hell.
Oh, no.
You're not hell.
They're all in there.
All the ones that are supposed to be.
That's always good, I suppose.
Are we?
We are, population is, has come down quite a bit, and we're only boarding out 4 right now.
Okay. To local Orange County or further?
We got 1 in Orange, 1 in Shenango, and 2 in Delaware.
Blake, do you have anything to add?
The only thing I would comment on is this presentation we just had, the other component that nobody talked about, the crime in this county,
Right.
mostly burglary, is directly related to the demand for the drugs. And, so there's probably a statistic that's missing off the chart here, that 399 per thousand, that's probably almost directly, related. You can go to any community you want, buy drugs illegally. I think, whether it's heroin or prescription drugs, it's out there. It's not just a problem that we all got to deal with. Your homes are not as safe as they could be because of the bad guys that are out there trying to get either your drugs or the proceeds of your house to trade for drugs. So, it's a driving force here.
Do you have anything you want to add, Jim? Thanks for helping this all happen. And so now, if we go very quickly, the first resolution was calling on Governor Andrew Cuomo and the state legislature to more equitably and efficiently impose the 911 surcharge on all wireless communications devices and use of revenues of this fund to finance county 911.
Moved by Jonathan, second by Kathy.
Thank you. Everybody, any questions, any discussion? Thanks for coming, Scott.
This is not the first time you put this resolution.
Well, this is coming from, part of the reason, and you can weigh in on this, Alex, if you want, is that if we don't do it, the money will go elsewhere. If we do it, that was my understanding, was that one of the direct results of the 75 million that's being used this year is because of all the pressure that's being put on.
Correct.
No, it's great.
Can't
We
hurt
need-
column.
Right.
It's in the can't hurt
We
column.
should do this every month. We want our money.
Pretty much, we want our money.
County, I mean, the 911 Coordinators Association is on this front, NISAC's on this front. I think every county in the state's on this front. And there's devices, prepaid cell phones don't pay the surcharge, iPods, iPads, you can, if you're on a Wi-Fi, you can fire up a phone, a virtual phone and dial 911. Difficult for us to track, yet, we feel that there should be a surcharge imposed on any device that can contact 911. So all that will do is allow more funding to create the technology and find the technology to locate these devices in the future, like we did wireless phones. So that's kind of the impact on it.
I think there is, in one of the whereases here, whereas 29 29 states have expanded their, it's the 1, 2, 3, fourth one down, have expanded their 911 surcharge to prepaid phones. So we've got that language in there, which is new. And basically, you know, I think the NISAC and the 911 coordinators do spend a tremendous amount of their lives just pushing this one item.
Contracts. People don't want to pay the Verizons and the AT&Ts, they just simply can't afford them anymore.
Right.
So they go out and buy a prepaid phone, and just pay monthly as they can, and we're not, you know, so surcharge money on the traditional, conventional cell phones is dropping because people are moving to prepaid.
So we, you know, we let them know we're not going away, and if that 75 million goes away, there will be probably mass demonstrations up there. The next one is.
All in favor?
Oh, sorry, thank you. Okay.
Or is it?
Calling on Governor Cuomo and state legislature to enact legislation to help county jails manage increasing costs of mental health services for incarcerated individuals.
Move it.
Second.
By Kathy, second by Alan.
Discussion. All in favor?
Or is it?
Hal, how's our mental health figures this year?
They're just climbing.
So.
Still there.
We have
Keeping Joe's people busy.
We have approximately 16 people with serious mental illness currently incarcerated at the jail.
60.
16.
Oh, 16.
Yes.
But that's serious. Then you have every step, you know, all the way back to quote-unquote normal.
Who's defining normal?
Unfortunately, me.
We're in big trouble. We're in big ass trouble.
That's
Yeah,
why
we
the
are.
number's so high.
No, we have a full-time social worker there, and she screens these folks. So, just so it doesn't go on YouTube that I'm doing.
So it's gone.
It's gone.
Thank you, Hal. Always injecting a good amount of levity.
And can I add, Cora, just one little thing to that
Absolutely.
before you take the vote? One of the things that we've put in place that has helped us reduce some costs over time is actually having that social worker in the jail, but also having an understanding between all the parties involved with that person, that if there's a person who has a serious mental illness and the person's there on a misdemeanor charge, you know, public harassment or just something like that, and they really have a mental illness that needs to be treated, we've gotten to where we're able to get that person out of the jail and into the appropriate treatment, and which actually does reduce the cost to the county in terms of you know, treatment in the jail, as well as, you know, prosecution and defense and all that. So I want to thank our partners, you know, in terms of their ability to look at the person and say, there's really no reason for that very seriously mentally ill person to be there. What they need is treatment.
Right. Well, that's where they get the treatment they need, not at Bushnell. So, Josh, remember last year you did a report for us on the number of people going up to Marcy? Are we keeping those under control?
We had one this year, and he was there for 30 days.
Right. So that's still, we're keeping control on that. So we already voted on that.
Yes, we
Now
did.
we're gonna urging the governor and state legislature to take action to relieve counties from the expenses associated with housing state parole violators in county jails.
Moved by Jonathan, second by Kathy.
Okay, I don't think that we need any discussion. This one comes up, it's another chestnut that comes up every year. Can you, Hal, just give the 2-minute Reader's Digest condensed version of the parole meeting yesterday? We had 3 people come from, I'm not allowed to call them state parole people anymore. What are they called?
Don't ask me, I can't keep up with it either.
Community corrections.
Yeah. Basically, these folks came down, and I think we got an education. I think it was our belief that they were just turning these folks loose in our community, where they actually do quite a bit of diligence prior to releasing these folks into Sullivan County. I think the meetings are going to be beneficial. They're, you know, it's going to keep them aware that, you know, let's take a close look at Sullivan County because of the issues that Sullivan County has. So I think it's going to be beneficial in the end.
Because everybody said, oh, they're not going to listen to you, there's no point in talking to them, and that proved that they did listen, and it is worth talking. Jeff, do you have anything you want to weigh in on that meeting yet from yesterday?
I think Al pretty much said it all. And I know Community Corrections uses our pre-sentence reports as a determination as to residency, and we've always included a general overview of a person's residency and our social history. We're adding a couple little blurbs there, both in the social history and the value of analysis, that specifically the person has had the majority of their residency within this specific area, and also if they have a transitory relationship with Sullivan County, that they're staying in a hotel, we would indicate that and indicate that they are not actually residents of Sullivan County.
Okay, that's helpful. Jim, do you want to mention anything from your perspective about yesterday's meeting?
No, I think it was a good meeting because it did open up the lines of communication, and they did seem to be receptive to our issues and the issues that we are confronted with in parole reentry, where there's a lack of really any meaningful programs where they're housing and the economic situation that we have here. That kind of puts a parolee at a disadvantage immediately because of the situation, whereas in other counties they may have a better shot because of better economic growth and things like that, where they can find jobs and have services that are there to help them become productive members of society, which is what we're trying to do.
Well, and that's a very critical part, that they have a quote-unquote successful reentry. And I think that one of the things that came out from the meeting yesterday is that we can't just look at one issue by itself. We are looking at housing. We do have this transportation subcommittee that's gotten a $75,000 planning grant, the issues of housing, transportation, workforce development, and community not-for-profit kind
It
of.
has to be a comprehensive approach, not piecemeal. We have to look at the whole picture.
All right. All in favor? Okay, it's 9:45. Thank you all very much for taking the time to come early. Really appreciate it.
Public comment?
Oh, more public comment.
No public comment?
I want to
Nope.
make a public comment. Dr. Holden's presentation was basically geared toward teenage drug abuse, is that correct?
That was what I saw on the screen.
Where's mommy and daddy? Where's grandma and grandpa? Where's aunts and uncles? Where's the family group? Why aren't the families dealing with some of this as opposed to us?
Well, I think that's the point we were making with Jim, is that it has to be a comprehensive approach. It can't just be the state or not-for-profits. That churches were also included in yesterday's discussion, so
I don't disagree with you.
I'm just saying.
everybody agrees.
He's looking at the stats in terms of deaths and that sort of thing, and everybody thinks a car crash is what kills young people, and it's changing. But these prescription rates that I'm talking about, this is not teenagers. This is
I understand.
everybody who receives a prescription and then and has it here in Sullivan County. That applies to grandma, grandpa, and everybody else.
Right.
It's not just kids.
If you can nip it in the bud,
True, and you need family intervention. And any of this
Absolutely.
stuff, and that's key. It's one of the things we talked about yesterday in parole. If you have family to support you when you come out, you have a better chance of success. And the same goes for treatment of drug addiction. If you have family there to support you, you have a better chance of success.
well, I was just basically
Right.
making a general statement about how far our society has come. And yes, that's sarcasm.
Well, I don't want to end on a sarcastic note. I do want to end up on a thankful note, and I think we are a very strong community. I think we're a tight-knit community. I think if we're faced with problems and we make it up our minds that we're going to work towards solutions, we'll be in a better place this time next year than we are right now. So I want to thank everyone who is participating. And it is now 9:50, and this meeting is adjourned.
Kathy?